Today I'm going to talk about patient immunologic endotypes of ischemia-reperfusion injury and liver transplantation. So solid organ transplantation is the primary therapy for end-stage organ disease and acute organ failure. However, the immune system remains the most formidable barrier to organ transplant acceptance and survival. So we know that the long-term survival of the grafts in patients is different depending on the organ. And so you can see here some long-term graft survival rates for kidney, heart, liver, pancreas, and lung, with liver being somewhere in the middle. But you can see that there are quite a few number of these transplants compared to other organs as well. So we know that patients also require a lot of immune suppression to be able to keep these organs for a long time. So we hope as immunologists that we will be able to balance the immune system's regulation once the patient has their transplant. So we're trying to reduce effects like cancer, infection, tissue damage, and allograft rejection. And we're trying to promote protective mechanisms that lead to tissue repair, debris cleanup, and allograft survival, and of course, ultimately, long-term patient survival after transplantation. So what can we do to be able to promote these mechanisms and functions of the immune system while still dampening those aspects that lead to pathogenic or undesired responses? So for liver transplant, orthotopic liver transplantation is the primary therapy for end-stage liver disease and acute liver failure. But ischemia-reperfusion injury, or something that I'm going to call IRI, is an unavoidable consequence of this transplant process when you remove the organ from the donor and then transport it to the location where the recipient is, and then, of course, add in during the transplant the recipient's blood into that organ from the donor. And then now there's this complex interplay between innate and adaptive immune systems of the donor and the recipient. So this plays a key role in the overall outcome of liver transplantation, or OLT. And at the moment, there's no clinical therapeutics or patient-specific diagnostics that are currently available. There are some cool techniques on the horizon, including machine perfusion, but we're not quite there yet, at least on a standardized basis. So in the beginning, when I first started looking into this many years ago, I just started kind of with the basics as far as this being what a hepatic sinusoid looks like inside of the liver at the cellular level. And so under normal conditions, which is what you can see over here on the left side of everything, you have parenchymal hepatocytes, you have stellate cells that kind of live in here in the middle between them and the L-sex, the endothelium, which you can see here is not fenestrated. Instead, the hepatocytes are where that is. And in the middle, where the blood flow is mixing, you see that there are also immune cell subsets, of course, white blood cells that are contained in that blood flow. So in particular, for ischemia-reperfusion injury, or IRI, we're interested in neutrophils, myeloid cells, and then the cells they can go on to activate later on. So during ischemia-reperfusion injury, or IRI, you can see over here on the right side of this diagram that things are starting to look pretty bad. So these hepatocytes are starting to exhibit a ballooning feature, which indicates apoptosis is occurring. And then you also see shrunken hepatocytes that can be very necrotic. They release certain molecules and lead to activation of more adaptive immune functions, particularly those that lead towards the deposition of fibronectin and other fibrinogens that lead to fibrosis, which is basically the death of a liver when you get something so extreme fibrosis-wise that we call it cirrhosis. So that's what we're trying to avoid, to minimize the damage done to the liver during transplantation process. And in that way, if we can dampen the immune system from these injury activities, then we can get to the place where the immune system's able to fight off things that it's supposed to, like infection and tumorigenesis. So this diagram here just shows you some of the sample types that we've been able to collect at UCLA in this particular study. This is just showing you that there's two different blood supplies inside of the liver. Not really an anatomically correct diagram, but just want to point out that we have obtained recipient systemic blood as well as portal blood. That is a combination of recipient and donor after the reperfusion event, because the recipient blood goes through the donor organ. So we take samples that are from the donor liver ahead of time, and then we also take a biopsy after reperfusion so we can see donor and recipient contributions in that biopsy tissue sample as well. And then, of course, we have lots of post-transplant time points that we're able to take lots of different kinds of samples for, so that we can do different immune assays and understand the patient immune status better as a result of donor factors or recipient factors or the injury process itself. So here is a timeline just showing those same samples, but how we obtain them across time. And the majority of the interesting samples that I'm going to talk about today really revolve around right at the time of reperfusion. So we have a pre-reperfusion sample right here, and that's a biopsy tissue, donor only. And then we also have a pre-reperfusion portal vein only recipient will be for this blood sample. And then we have the two post-reperfusion samples. This blood sample will be donor and recipient, as well as this biopsy. Also, this post-reperfusion biopsy, which is obtained about 2 hours post-reperfusion, is used for the IRI scoring process. So how do we do scoring at UCLA? What features can be seen in IRI positive patients at the 2-hour post-reperfusion biopsy time point? This is one of the most common questions that I get. It's very early. And when you take a look at mouse models, we're performing those experiments, depending on the model, at least 6 hours, usually 12 or 18. So why do we do this so early in humans? Well, there's quite a few features that we've seen at UCLA. Our pathologists have been reviewing mouse rodent studies as well as the humans for many years. And this is 4 examples from 4 different patients on what their tissues look like. And they're all considered IRI positive. You'll notice that what's common amongst them is these top 2 right here, inflammation and necrosis, which is the black arrows and the red ones. All 4 of the patients have a combination of those features. However, most of the patients also have some other concomitant pathology that you can see in their histology. And so this includes congestion and hepatocellular ballooning, which, remember, we saw was a sign of apoptosis processes. Fatty liver steatosis. This is macrovesicular steatosis. These really big, large fat droplets. And cholestasis, biliary cholestasis is another thing that you can see here, evidence of in these patients. So our pathologists basically have a scoring system for these 2 major features, inflammation and necrosis, depending on the location of them and how many there are. But we also go ahead and score congestion, ballooning, macrovesicular steatosis, and cholestasis, just so that we can get an idea of how those features play in. So one of the first things that we learned about these patients is that bilirubin levels are increased in IRI positive patients at POD 2 and 3, and the AST levels are increased in IRI positive patients at POD 5 and 6. So we noticed that ALT and INR levels weren't different, but bilirubin and AST were at different time points. So we could kind of use those clinical liver function tests to be able to judge our patient and see whether or not they're suffering from extreme IRI or not before we're able to get the biopsy back in some cases. So our goal here now is to just minimize the effects of this ischemia-reperfusion injury, again, so we can lead towards protective mechanisms. So we found in our first look at this, we found all these different cytokines at different time points that we were able to relate back to these different LFTs, as well as the reperfusion and ischemia injury on the tissues. So we noticed in particular that a couple of signatures stood out to us at this early time point, which was the signature of IL-1 beta and TNF alpha. So as I showed you earlier, we're looking into neutrophils and myeloid cells and looking at these injured hepatocytes and trying to see what products are dumped out into the environment that these APCs or macrophages could be able to respond to. And so we took a look at the pattern recognition receptors that these stamps were able to activate and kind of expanded this portion of our figure here. So we used a pattern recognition receptor analysis assay that we developed in conjunction with the lines that were available from InVivogen. And so here you can see all the different pattern recognition receptors that we tested right up here at the top. We compared them to endogenous ligands or natural ligands or synthetic ligands, depending on what was recommended by InVivogen as well. These are the positive controls for those. And then we compared patient liver flush samples and portal vein samples, which is recipient only or donor and recipient after reperfusion, to be able to determine which one of these was being activated. And we came up with these four, TLR4, TLR9, were being preferred by IRA positive patients, and then TLR7 and NOD2 seem to be higher for IRA negative. So we came up with this patient-specific PRR reactivity screening profile, wherein that if your patient came in for a visit and you ran this panel, then you would be able to see, okay, this is an IRA negative patient because they are above average on NOD2 and TLR7, whereas this IRA positive patient, you can see that they have a very strong signature of TLR4. So we came up with a CART analysis and found that TLR4 was the first dividing feature, that this was able to separate IRA positive and IRA negative patients quite accurately. And the sensitivity and specificity for these PRRs was quite high. So trying to come back to these figures and understand a little bit better what could be activating those PRRs, we started to investigate what was in the blood samples that had been used to activate them. In our collaborators' mirroring studies, we had shown that injured hepatocytes and those liver endothelial cells, LSECs, release this stamp called HMGB1 during the process of IRI. And that binds to PRRs like the TLR4 that we identified in the humans on these parenchymal cells, inducing pro-inflammatory cytokines like TNF-alpha. So the aim of this study was to determine whether or not those PRRs were activated via this molecule called HMGB1. So the first thing we did was a time study to try to determine when HMGB1 could be detected and in what sample type. And we found, you can see here, this is a log scale. We found lots more of it in this liver flush sample, which again is the post-reperfusion sample with both recipient and donor blood that has just been flushed through the organ. So you can see here when we stratify this by IRA positive or negative, though, the presence of HMGB1 doesn't really predict whether or not you're going to have IRI. So we went back to the drawing board to try to understand the HMGB1 studies, and what we found was that there's actually different oxidation states for HMGB1, and you can tell that depending on the different localization within the cell when you're talking about active secretion. So passive release of HMGB1 can be achieved when there's damage to a parenchymal cell, but this is going to release a more reduced version of it. However, active secretion can come from monocytes and macrophages only, and you can tell this is happening because it's translocated out of the nucleus into these vesicles for secretion, similar to a cytokine. So this format is called disulfide HMGB1, and it's heavily oxidized. So we did a Western blot assay for this. This was very difficult to do. The separation is 28 versus 25 kilodaltons, but you can see a difference between all-thiol, which is here in the top row, versus patients with disulfide HMGB1. In particular, this patient I'll point you to is an IRI positive patient with only disulfide. So we took a look at this, looking at the ELISA for HMGB1 and then comparing that to the ratio of disulfide versus all-thiol in the Western blots, and came up with this analysis to figure out that the IRA positive patients had much more disulfide HMGB1 than IRA negative, and this is probably what was playing the role. So we wanted to confirm this using the histology, so we used this digital technique that I developed during my PhD years at Texas. And basically using this technology, you can see the HMGB1 in the different vesicles and determine whether it's being secreted like this right here appears to be. So basically, this is what the method looks like. You take raw images in the confocal microscope and you digitally extract the macrophages, only the portion that you want. And then you can look inside of them or outside of them to see where the HMGB1 is. We utilize this technique here, and you can see in the top IRA negative patients don't have the HMGB1 in vesicles. It's very spread out all across here. Maybe some minimal packaging here in these foci. But you can see the IRA positive patient, almost all of the HMGB1 is translocated away from the nuclear compartment into these vesicles for transport out. So we believe that the majority of this is disulfide HMGB1 being produced by macrophages in the IRI. And here's the graph just quantifying the differences in these two different macrophages coming from an IRA negative or an IRA positive patient biopsy sample post-reperfusion. So we wanted to confirm that this was a feedback loop going on in macrophages. And so we did feed HMGB1 disulfide to the macrophages, and then eventually they started upregulating these receptors, spitting out TNF alpha. So we know that this did lead to increased pro-inflammatory phenotype for them. Now, going forward, we started to look into the T cell compartment and how those macrophages change that. And so far, we found memory versus exhausted T cells in the IRA positive versus IRA negative patients at 3 months after the transplant, and which you can see here as evidenced by the balance of TIM1 versus TIM3 positive T cells. And then the other thing that we've been working on is assessing the crosstalk between IRI and alloimmune responses, which would really be B cells and their role in producing antibodies, and specifically donor-specific antibodies. So we know that patients who have IRI tend to not have donor-specific antibodies in the beginning, but then develop them much later. Whereas patients in the beginning who do have post-transplant antibodies, it seems to tolerize the patient against the allograft. And so in the IRI, they have much less of it, and then they go on to have much less donor-specific responses and third-party antibodies produced late. So we've updated this figure quite a bit over time. This is kind of the left part that you saw before, and now we've upgraded this whole right-hand side to show us some phenotypes for these patients that we can now use to evaluate them in the clinic. So there's the IRI negative, low risk, TLR7 NOD2 mediated endotypes that end in immune regulation, T cell tolerance, and a functioning allograft, versus the IRA positive high risk TLR4 and TLR9 endotypes that lead to increased T cell activation and subclinical or even clinical alloimmunity evidenced by these anti-HLA DSAs, and then that causes long-term subclinical graft damage, which can eventually lead to dysfunction and graft loss. So just very briefly, I'll show you how we use these endotypes to identify certain patient cohorts that are at higher risk. We've taken a deep dive into patients that have non-alcoholic steatotic hepatitis. And so this is an advanced form of non-alcoholic fatty liver disease where there's inflammation added in to the fatty liver. Once that happens, then you can get pretty severe fibrosis. And as I mentioned earlier, cirrhosis is kind of the end stage for the liver, and then you need the transplant. So unfortunately, the prevalence of this disease amongst Hispanics is quite high. And you can see that the more clinically relevant version of this NAFLD, which is NASH, is also elevated and abnormally high in Hispanics. And here in Southern California at UCLA, we have a very large Hispanic population. So just taking a look at this NASH etiology for transplantation, because of our new drugs for HCV, now we have a lot of new OLT waitlist registrations for NASH etiology. That's quickly becoming our highest priority here. This has increased over 170% recently. So are Hispanics more sensitive to immune responses? What is going on with these patients? So we've been able to categorize them just based on those assays that I already mentioned, and noticed that not only do they have increased hepatocyte inflammation in the beginning before they even get the transplant, and are usually presensitized to HLA antigens ahead of time, although that was not just due to increased parity. We did investigate that. There's increased pre-transplant cytokines as well because of the NASH. So the combination of these factors regardless of what kind of donor liver they get, but often they do get poorer quality organs just because they have smaller body sizes and we need to match them as best we can. We find that post-transplant, they have their own increased PRR reactivity profile. They always get increased ischemia-reperfusion injury. They have the canonical increased pro-inflammatory macrophages associated with the TLR4 endotype, increased hepatocyte apoptosis and macrovesicular steatosis, and worsened outcomes within the first year post-transplant, including death. So this has just been accepted in transplantation. And with that, I'll just say thank you to all the members of the labs that have worked with me over the years to do this project, and I'm happy to take any questions.